Thanks very much, Azmi. Good afternoon, everyone. Right, okay, so I suppose I should start my disclosures and then very quickly move on to our learning objectives. So I think what we probably need to do is to really get a good grasp of the concepts behind how CGM came about. So we're going to focus a bit about glucose variability, which most of you already know about, but also look at how the data has been presented in the form of an ambulatory glucose profile. And then this, fairly or relatively new concept of time in range, but it has been around for a while, but it's gained momentum. And certainly there's been a guidance, national guide, well, in fact, European guidance back in 2019. And then how we use all that data to interpret CGM, which is key from a healthcare professional, but more importantly, from a patient point of view. And very quickly, I'll just touch upon about what available technology is out there. And then if you've got time, I've got 3 cases to illustrate some of the discussion points, and then you can ask me questions at any point at the end of it. Right, okay, so let's talk about glucose variability. I'm sure you know what glucose variability is, but it's always nice to relate glucose variability to our gold standard way of assessing one's glycemia, which is HbA1c. And for those who are not familiar with glucose variability, if you just pick the top left-hand corner of the graph, the squiggly lines reflects a particular day, and the color basically reflects a different day of the week. And typically you get a conglomerate of 14 days amalgamated in a single graph, and hence, it's the way it's been presented at the moment. So what I wanted to use these graphs is to illustrate the point that if you look at both the top 2 graphs on the right and the left, both these patients have almost same HbA1c, fairly good HbA1c in fact. But if you look at the left top hand corner, very good variability, very narrow variability for that matter, very marginal days where there's small episodes of minor hypoglycemia. So that HbA1c in that respect is very, very safe. If you look at the top right hand corner, same HbA1c, but huge difference in terms of variability. You can see the swings ups and down, and lots of hypoincidences, as you can see, and also highs. And this clearly has a major impact on the well-being of this patient and also the long-term risk of complications. So just makes the point that there are pitfalls with HbA1c, and this illustrates that very nicely. The bottom 2 graph illustrates the fact that if you get someone with very low HbA1c, first thing you need to be suspicious is that are they having lots of hypo. And if you look at the bottom left-hand corner, yes, very low HbA1c, but very narrow glucose variability. If at all, there's a slight increased preponderance to its, hypoglycemia overnight or early hours in the morning, but not too bad. But when you compare to the bottom right-hand corner, you can see that big variability, very high risk of hypo, and that ties in very well with the low HbA1c. So it just illustrates, when you see someone's HbA1c, just bear in mind, is it representative of their true glycemia? What is the variability? And if you've got the means to check the glucose variability in some form of CGM, it's extremely important to have a look at it. Right? Okay, so when we talk about glucose variability, it's not, it basically entails, the reason why you get glucose variability, there's 2 parts to it. You can get glucose variability within a day, but also variability from day to day. So if you look at the left-hand corner of the graph, that's a typical glucose excursion after a meal. So, that's a variability, a variable excursion in itself, but that can be replicated every day, but in a different waveform. So that lends into what we call, day-to-day variability. So you already have, in-day variability made worse by the fact you got day-to-day variability. So that whole state of flux leads to a significant increase in hypoglycemia. So that's why we're very, very interested in glycemic variability or glucose variability. Right, so we've got a huge wealth of data, and you get all the squiggly lines, and how do you make sense of it? And before AGP came about, if you download a typical pump, for example, pump data, and if a patient is on CGM, it's really just very hard to work out. If you look at the summation of the data, where's the head and tail, what do I do? And there's a lot of guessing work that needs to be done. And there's that danger of, giving the wrong advice to patients. So consequently, there was a consensus looking at how we should present the data in the form of what we call ambulatory glucose profile. And this is a very nice summation of typically a 14-day data. And what it does really, it puts it in a very nice format in terms of interquartiles. So if you look at the dark blue line, that's your median, line, and that tells you, in inverted commas, what your average. But the dark shade blue above and below, that's your 25th and 75th quartile, and what it tells you, that's the kind of range 50% of the time the patient spends in throughout the day or throughout that typical profile. And then the lighter shade of blue reflects what happens over the 80% kind of period. But certainly what it tells us, that's less common. The patient spends less time in those kind of areas. And then obviously you've got the extremes, which is not really reflected on the graph. Those are few and far in between and wouldn't help us in terms of interpreting the AGP. So that's been ignored or deleted from a typical AGP. And then you can see that you mirror the data or overlap the data with a typical target range, typically 3.9, 10. And it tells you, it lends in that information about time in range, which we're going to talk about shortly. But you can additional data as well. You can estimate it HbA1c, it gives you a daily average, and it really gives you a very nice, what happens, right across the day over a 14-day period. So what's important to recognize is when you look at the AGP, just to reiterate the point, that the dark shade blue above the median line represents what's usually happening in terms of variability. The wider it is, the bigger the variability, but that's where you spend most of your time, give and take. The lighter shade, very occasionally you're in that area. Might help, might not help, but something to bear in mind. And what's interesting is that the surface area below the median line actually is where we calculate the estimated HbA1c. And that just shows very nicely how that number is derived. So consequently, you can actually plot an AGP for various groups of patients. So typically in someone without diabetes, you would expect it to be, fairly flat. You're flattening the curve, the usual term that I've been using lately. And someone with good control, again, it's very flat with some minor variability. And then on the right side, both the graphs, particularly on the top one, you can see, the sugars are high, the time in range, above range is very high, but saying that the variability is very narrow, making it more predictable. Any changes that you're going to make will give you some element of safety netting basically for the patient. So it's much easier to influence change both on the HCP point of view and patient point of view if the variability is narrow, because it's more predictable. And if you look at the right hand bottom corner, the variability is quite wide. Again, it poses a lot of challenges in terms of risk of hypoglycemia when you're trying to optimize or fine-tune the insulin bolusing or basal that's needed for the patient. So you need to bear that in mind when you see AGPs.
Shafie, can I just ask a quick question? Some of the SPRs were wondering whether you would be happy to share the slides afterwards or not.
Yes, I'm very happy to share the slide because I think you've got a copy already, so feel free to give it to everyone. No problems at all.
Thank you.
Right, okay, so the term time in range, I'm sure all of you have heard of time in range, and I must say more and more now I look at time in range. I do look at HbA1c, but the for HbA1c is more significant if the variability is narrow and the time in range is high. So I would explore HbA1c because it does have an influence in terms of long-term prognosis and so on, or risk of complications. But in effect, so time in range, can be displayed in a traffic light system, which makes it very easy to follow from a patient point of view. And I specifically, I really love the traffic light system because it tells me what I need to know really. And obviously, time in range, you need to have a target, and typically that target is between 3.9 to 10, which is the current accepted time in range. So the concept then expanded in the sense that what is a normal time in range? And there's a general consensus that for the majority of patients with diabetes, be it type 1 and type 2, you're aiming for a time in range in around about 70 to slightly above 70% if you can achieve it safely. And that's again between 3.9 to 10. But also they went on to define what is time below range. As time below range, ideally you do not want it to be above 5%. Obviously, if you can have it 0, that's better. But also they further define what is time below range in terms of the glucose threshold. So you shouldn't have more than 4% time below range between 3 to 3.9, certainly less than 1% below 3 millimoles per liter. It is inevitable patients would be at risk of hypoglycemia. You will never be able to eliminate that. And again, when you look at the time above range, you're talking about anywhere between 25 to 30%. And one would think that that's quite high, but in effect, if you achieve this kind of combination of time in range of 70%, in essence, your risk of complications is quite low if you maintain it over a prolonged period of time. And the consensus basically also came out with individual situations, what you would expect for time in range to be. So, for example, the majority of patients with type 1, type 2, like I just alluded to, you're aiming for above 70%, provided safe to do so with low risk of hypoglycemia. For those patients who are at significant risk of hypoglycemia, particularly our elderly population, those with significant loss of hypoglycemia awareness, and certainly there are certain extenuating circumstances such as renal impairment, for example, where the risk of hypo is high, then you may want to aim for a much lower time in range. And again, that would be reasonable for that patient. So it's about individualizing time in range. It's a bit like what we've been doing in terms of individualizing HbA1c, for example. And then there are specific circumstances for type 1 diabetes in pregnancy, and certainly for type 2 diabetes and gestational diabetes, where the time in range attainment can be much higher, and we should really go for it. So quite a nice way to illustrate what are the things to look out for and what you should be working towards for individual patients. Just to reiterate the point that you cannot achieve time in range without taking note what is the time below range. Because if your time below range is very high, there is no point looking at time in range because you might perpetuate or make it worse. So you need to focus on reasons why that's happening. If there's a very high incidence of hypoglycemia, you need to address that first before you can safely increase time in range. So it's a bit of a logical step because you do not want to cause more harm to the patient. So in terms of how do you correlate time in range with HbA1c, and the evidence base behind this is quite soft, but there are lots of articles, lots of small group of numbers of patients being collated, and then they plot their time in range against HbA1c. And in a nutshell, you get a feel that if you've got a time in range at 70%, actually your attainment of HbA1c is about 6.9%, which is really, really good. So understandably, if it's low, such as 40% time in range, you're thinking about an HbA1c of 8.1%. Now, before, when I came to understand time in range, I was expecting, a much higher HbA1c with time in range of 40%, which is not really the case. So, there's a lot of leverage there in terms of how individualized time in range for patients. So it's nice to see this, to get a reasonable idea what your HbA1c is, because that's the terminology that patients are very used to, and we as healthcare professions are very familiar to as well. So it's always nice to have some sort of relationship between TIR and A1C. So what's the evidence behind it in terms of time in range? So if you look at DCCT, a very old study in the type 1 population, obviously they were not using CG, but they were using an increased number of point areas where they were doing self-monitoring blood glucose up to 7-point profiles. So it gives you some sort of surrogate marker of time in range. And it does show that the higher the attainment for time in range using this 7-point profile, the lower the incidences of retinopathy and also micronuria. Some surrogate evidence to show that the longer we stay within range, and in this case, it's around about 44 to 50%. In a standard deviation, about 15%. And despite such a low attainment time in range, you can see that the incidence of retinopathy is much lower in those patients, and microalbuminuria as well. Other evidences looking at more recent CGM trials, your Diamond trial, your HypoD trial, there are various types of CGM. Again, right across the board, you want to make to understand the relationship between mean glucose, time in range, and HbA1c, and again, it mirrors what we understand from the DCCT surrogate studies to confirm that there is a relationship, and hence you can reproduce these findings. So in essence, you've got a wealth of information, and it's always nice to bring it together. And a typical AGP setup, what you will see is that you get numericals to tell you how many percent. I quite like the traffic light system because it tells you what you need to see, and patients appreciate it better. And then you get the AGP to look at your variability, to influence your decision making. But also, we tend to forget one bit of the data, which is your daily glucose profile. That gives you a bit more granularity in terms of what happens on the data, and might give you some insights in terms of how you want to influence improve glycemia. So I would definitely look at everything. But from a patient point of view, you need to keep it simple. I think the traffic light system is quite good. And there's some pearls of advice that we can give them, which I'm going to allude to later on in the talk. So we're down to CGM interpretation. And we're at the crossroad. And I always view CGM as, who is it most useful for? Is it the patient or is it the professional? And it's always very important to be mindful of this, because it's not, these tools are primarily for patients. So real-time data is extremely useful for the patient. For the healthcare professional, really, majority of the time you're using retrospective data. But the longer, in terms of when we bring them to the clinic, and if you've got retrospective data that's, let's say 6 months ago, then the value of that data becomes less relevant. There's no 2 days are the same. So you need to bear that in mind. And I have not come across a situation where a healthcare professional takes note of real-time data, because then you'll not be able to do anything else. So you need to empower the patient to be able to use real-time data to influence their glycemia. So as I've said, it's primarily useful for patients. However, there's a huge amount of information. So you really need to empower the patient on how best to use the data in a practical sense. And always be mindful, because too much data can be very overwhelming. You may put them off, and it's an expensive tool. So it's worthwhile spending a bit of time from the outset. What kind of data should they be looking at? And I've learned through my patients in the early days when I started CGM, I just used to give the CGM without giving them much information about what to expect. And I realized that that was the wrong thing to do, and we need to be very good at this to be able to give them the right information. So worthwhile pre-planning, picking your patient and sitting down with them and explaining to them, what to expect. And this is where we expect our diabetes specialists to be particularly good at as well. But as consultants and registrars, we need to show leadership and understand exactly what it means. So the most useful information from a patient's perspective, and I think there were some studies looking at surveys when they asked patients in CGM, what is most useful for them, they find the trend arrows is extremely useful. And certainly the alarm settings, for your low alerts, high alerts can be useful as well. But there's something about the high alerts that you need to be careful, which I'm going to allude to shortly. But ultimately, the CGM data is only useful if you're using it more than 70% of the time. If you're using it less than that, the value of looking at the data becomes less, it carries less weight, so it's pointless. So you really want to encourage patients to use CGM more than 70% of the time, so that the data carries weight. As I've said, the retrospective data is useful for the healthcare professional, but you want to have the recent data. So ideally, when you see the patient in clinic, you want to look at the data in the last 2 weeks, probably last month. but I wouldn't go beyond that really because it's less helpful. Before we had real-time CGM, we used to do blinded CGM, whereby we give them a device. If the device doesn't tell them what the blood glucose is, well, the sensor glucose is doing, I find that very, not helpful in these days. Probably there's a small cohort of patient or niche area you would probably use blinded CGM. I don't use blinded CGM at all now because I think there's a loss of opportunity for the patient to understand what's going on, even if it's a short trial, to understand what's going on in terms of the glycemia. So when we try to explain to patients about CGM, one of the concerns they always have is that, is it accurate? And if you don't explain to them that it's not, there's always a lag, what we call a sensor lag. If you don't explain to them about this phenomenon, they will lose trust in the device. They will go away and then come back to me and say, you know what, I don't trust this device. It doesn't tell me exactly what it is, because they don't understand that what we're measuring is interstitial glucose. There's always a lag. Particularly if the delta change in glucose is rapid, in other words, the drop or the rise in glucose is very high, the lag is even more significant. And those are the areas where patient finds that, oh gosh, it's really way off, and that's to be expected. What you want them to recognize is that it's changing rapidly and that they can take evasive maneuver. The absolute values doesn't really mean anything, because as you know, if your arrows are vertically down or vertically up, we would want our patients to do capillary glucose testing to get some degree of accuracy and intervene as depending on the results. So you've got your downswings, upswings. Those are the areas, particularly when it's acute, that can be, there's a significant lag. And then if you're on CGM, any rapid change in the sensor glucose, depending on your setup, will lead to an alert. And we can set the alert at what thresholds do you want it to come into play. And there's some predictive element that you can put in as well to pick it up way before they hit the low threshold. And that applies to the high alerts as well. I mentioned earlier that be very careful with the high alerts, because normally when a patient is new to CGM, I try to ignore the high alert settings, because if you get too many alarms, the patient gets alarm fatigue. And again, you start to switch off. It's a bit like how these days we get tons of emails every day. You tend to just pick and choose what you want to see, and you ignore the rest. And because you get so much info fatigue. So in this case, what I would do is set realistic targets, and I would focus on hypo alerts first before I think about high alerts. And I would be very generous in terms of the threshold for the high alerts if I were to put one in place. Most definitely over time, we will explore that, but the focus primarily based on the current guidance for CGM is to minimize the risk of hypo. And from a patient point of view, aside from the number, they'll have arrows, and they will see that you've got a flat arrow, or what we call a horizontal arrow. I would call that a coasting arrow, not much change. And then certainly diagonal, up, down, double arrow, double down arrow. So these are all very important clues as to what's the trajectory of the glucose. And it is extremely important we teach our patients, what does it mean? What do they need to do? It depends on where the scenario is, basically. So let's talk about alerts. There's so many types of alerts built in all these devices, but I've just highlighted the important ones in yellow. And what I would pay particular attention to, the first one is the low glucose alert. So for example, you can set it at, let's say, 3.5. But the predictive low glucose alert is quite useful. In other words, the system can warn the patient that within the next 20 to 30 minutes, I expect the glucose to hit 3.5, which is your low glucose alert. And that's quite useful, because then the patient knows that I'm heading that direction. I can do something to avoid me from getting into the hypo territory. So that's very, very useful. And you can reciprocate that for the high glucose alert as well. And as I've said earlier, I tend to set it a bit higher, anywhere between 16 to 20. And I try not to do the predictive high glucose alert, because I can bet you the alarms will go off and they'll just get alarm fatigue. So, you need to put yourself in the patient's shoes in terms of what area is it that you want to fish out to keep them safe. In terms of arrows, and again, these are general principles. And if you want to put a number to it, this is what it, in a ballpark figure. So if your arrow is pointing vertically upwards, you're looking at a change, a 1 millimole change occurring within an average, 7 minutes period. And if you look at 30 minutes, you're expecting a 3 millimole rise in the glucose. If it's diagonally pointing upwards because of a slow change, then that 1 millimole change would take probably over a period of 15 minutes. Over half an hour, you would expect a change of somewhere between 2 to 3 millimoles per minute. And then if it's coasting, there's still some change, but albeit on a much longer period and smaller margin of change. And then it's, you just mirror that to the downward trend, and the numbers are almost similar in terms of time millimole change. So it's a nice way of keeping an idea as a healthcare professional, what kind of changes to be expected. I must say, I don't show this to patients because when you give them too much information, it can be overwhelming, but I'll give you some clues later on in terms of what are the pointers we can give to patients when we look at arrows. So when you've got a CGM in place, you need to bear in mind in terms of, is it post-meal, pre-meal, which part of the day are you looking at? Because then it will influence what you're going to do when the sensor glucose is high. So for example, if you've got a sensor glucose of 13, the actions that you're going to take will differ whether it's pre-meal, 1 hour into your meal, or 2 to 3 hours post-meal. The actions are completely different. Hence, you need to be cognizant of this. And the reason for that is got to do with this concept of insulin on board, which I'm sure most of you know, but I'm quite happy to elaborate that later if you want to ask me a bit more details about that. So the calculations that you're going to make is pretty much determined by where are you at in relation to meal, and when did you bolus your insulin? Is it before meal, right just before the meal, or way before, such as 30 minutes or so, give and take. So let's take one example here. So what happens then 1 hour into having bolused for a meal? So in this case, this patient's sensor glucose is 16.5 1 hour into the meal, and the arrow is pointing diagonally upwards. And within an hour, you would expect a sugar rise. But then you need to ask, that's a big change. That's what 8 to 10 millimoles change from the target. So if you look at on the vertical line at 6 p.m. or 1800 hours, the blood glucose, sensor glucose is around about, give and take, around about 8, 9, and 1 hour later it's 16. So there's an 8 millimole change or rise in sensor glucose over that 1 hour period. And that typically tells you or gives you some insight into, one, the timing of the bolus of insulin, or two, could it be there's an issue with their carb ratio, or have they underestimated their carbs? So there's a lot of things that you can think about in terms of offering advice. But from a patient point of view, what I would normally say is that there's an opportunity to look at, would it be possible to do your boluses at least 15 to 20 minutes beforehand? Only if it's possible. I know it's not easy, but if you can, it'd be worthwhile, and we'll explain why. And that's all got to do with insulin on board. And okay, again, so a slightly different scenario, 1 hour into your post-meal, and now the blood glucose is, sensor glucose is 11.7, but the arrow is coasting. Again, as we know, there's still some changes, but the changes are going to be minuscule over a long period of time. And it is likely that in this case, the patient may have bolused at least 15 to 20 minutes before, because the degree of rise in the glucose is around about 3 to 5 millimoles. So again, if you take it at 6 p.m. or 1800 hours, it's about 8, 9, and it's now 11. So it's anywhere between 3 to 5 millimoles rise. There's a very good chance that they're bolusing in much earlier. And it's worthwhile asking patients if they can do that as best as they can, understandably guided by their schedules and so on. So what happens 2 hours, so 1 hour. Remember, if you're using a quick-acting insulin, it kicks in within 15 to 20 minutes, give and take. It peaks by 2 hours. By 4 hours, it's out of the system. That's the concept of insulin on board. So at 2 hours, there's very little value, to do anything if the sensor glucose is high, regardless, whether it's pointing vertically up or not. but certainly if it's pointing downwards, there's something to be noted. So for example, in this case, you can see it's 2 hours down the line, glucose is 13.7, but it's coming down. And it's 2 hours, you would expect you still got about 50 to 60% of insulin on board. So insulin is still working. Would you do anything? Probably not. And this may be a reflection of the glycemic index of the food, because you've got quite a significant low glycemic component, glycemic index component in your food, then that's probably the reason why it's taking a while for it to come down. So those are the factors that you need to bear in mind. But I wouldn't do anything because it is very likely it's going to come down at 3-4 hours. I would not do a correction at this point because I know the arrow is pointing downwards. And so just to give you an illustration again to reiterate the point that if you look at postprandial glucose bolus of insulin 20 minutes before, at the time of meal, and 20 minutes later, and you can see that the diamond-shaped line is the 20 minutes before. You can see it flattens the curve because your insulin is kicking in much earlier in anticipation of the glucose rise, as opposed to giving it at the time of meal and 20 minutes later. So there's a lot to be said. If a patient is able to bolus before, by all means, I would go for it. And this is particularly true for the newer closed-loop hybrid closed-loop systems, such as your 670G hybrid closing. We normally advocate you really need to bolus 15-20 minutes before to flatten the curve, because if not, then the system will have to give a huge amount of insulin, the alarm will go off, and it's just going to create a bit of chaos. So you need to plan ahead. Right, okay, so what happens then at 2 hours, and if let's say the glucose is below, sensor glucose is below 6 and it's pointing downwards, and this is the scenario where you may want to do something. So 2 hours down the line, sensor glucose below 6 and the arrow is pointing downwards. Now, and that could imply that I might go hypo. And what I would normally say is if it's pointing downwards in a diagonally fashion or one arrow, then I'll probably give somewhere around about 5 grams of quick-acting carbohydrate. So that might be 1 jelly babies. But if the arrow is pointing vertically down or double arrow in some of the systems, then I would probably give 10 grams of quick-acting carbohydrate in the form of probably 2 jelly babies. But it is also worthwhile for the patient to pause for a moment and say, and ask themselves, why is this happening? Have I overestimated my carb? Is there a problem with my carb ratio? Is it because of my exercise not too long ago? Or have I been having lots of hypo today? Because it's worthwhile explaining if that's a recurrent phenomenon, because again, that might influence how we improve things moving forward and avoid any significant hypoglycemia. So it's worthwhile bearing that in mind. So 3-hour glucose. So this is where you probably utilize 60% of the insulin bolus that you've given prior to the meal. And let's say in this case, glucose is 15. And the arrow's coasting, and you know that the insulin on board is running out, and it is quite high. In this case, probably more than likely I would encourage a correction dose. Now, with regards to the correction dose, depending on your insulin sensitivity factor, you might just want to half that so that you don't overdo it, because what will happen is then you'll end up chasing your tail, and it's what we call a roller coaster effect. So be mindful, not to too aggressively correct, because don't forget you still have insulin on board. So having the worked out correction factor based on the insulin sensitive factor is probably the safest way to do things to do in this kind of situation. And certainly if it's going downwards, then I would sit tight, because the arrow is pointing it's coming down. Yes, it's a bit high at 3 hours. Let's hang fire. Let's see what's going on. I wouldn't intervene, because if you zealously correct here, you definitely get a hypo, and then you're having to recorrect, and you'll end up like a yo-yo effect. So again, sit tight, know your arrows, know where you are and how many hours after your meal. Think about insulin on board, and you must be able to explain this to a patient in a non-jargon way. And I quite like using pictures and graphs and explain to them how it works and so on. So it does take a bit of time, but time well spent, because if you get it right from the beginning, it'll be smooth sailing after that, much easier for the patient and yourself. And it's also part of rapport building as well, because then the patient as well trusts you, because they can understand, what you're trying to do, and you build that relationship. Right. So now we are moving on to pre-meal. So what happens then if, let's say, you're about to have a meal and your sensor glucose is high, and there's also that factor about the arrow pointing upwards, coasting, or downwards? What do you do? And there's several ways to address that, and there are three possible options. Some people use the ISF base rule, some people use the predicted glucose rule, and there's this thing called 10 to 20% rule. I must say, from a patient's perspective, easier to use the ISF or 10 to 20% rule. The predicted glucose rule, there's too many calculation. I don't want to overburden patients with those numbers, but that's the principle that they use in automated system. So let's pick an example. Okay, so there's certain assumptions that you have to make for the ISF rule. So again, just remind you, pre-meal, you're about to have a meal, sensor glucose is high, and I've got an arrow. I want to do a correction, but with that additional information with the arrow, what else do I need to do to safely navigate through once I've injected? So the assumptions are that for the adjustments that you have to make, in this case, your ISF is anywhere between 2.5 to 4 millimoles, and your total daily dose is anywhere between 25 to 60 units per day. So if your arrow is pointing vertically upwards, then what you do basically is you obviously your sensor glucose, let's say it's high, 13, let's say, and you've got about to take some amount of carbohydrate, so you carb count for that, and then you work out the correction factor, but then you've got this additional information, the arrow, you add 1 unit on top of it. If your arrow is pointing diagonally upwards, it's slowly changing, it's half a unit. Very easy. So it's 1 unit, half a unit, depending on the direction of the arrow, and it's just the same thing if it's pointing downwards, albeit you take off half a unit or 1 unit. That obviously changes if the patient is more insulin resistant. As you can see in the small box at the bottom, if your total daily dose is more than 60 units or less than 25 units, then you make adjustments accordingly. Very basic, very simple. The rule of the rule of the game is looking at where the arrow is pointing. Is it acute? Is it an angle? And that's either 1 or half a unit, depending on whether it's high or low. Very easy, and most patients understand this. So that's just an example for the ISF method. So patient is about to have a meal, sensor glucose is 9.2, and the arrow is pointing at an angle upwards. So that means if I'm going to do a correction, I'm going to add half a unit on top of my calculated carb ratio and correction factor. So in this case, this patient's correction insulin to carb ratio is 1 to 10. The correction factor is 3. And he or she is about to take 40 grams of carbohydrate, so that's 4 units. But because he or she is off their target of 6, which is your target glucose, so you're 3 millimoles off, and the ratio is 1 to 3 for ISF. So you add 1 to 4, you get 5 units. But because the arrow is pointing such, you get another half a unit. So it's 5.5 units that you take before a meal, and that will definitely help to flatten the curve post-meal. The 10 and 20% rule, same principle really, so if you're pointing upwards, having done all the calculation, then you're at 20%. If it's pointing diagonally upwards, you're at 10% because it's a slow change. And then the opposite is true if you're going downwards. Again, I quite like using this because it's very simple. Some patients also, prefer this rather than the ISF rule, but the principle is the same. And if you work out the maths, it's not far off. It's what give and take half a unit different. And I'm not going to go through the calculation. As you can see, it's fairly straightforward. But for the predictive glucose method, there's more calculation to it, and you can easily do it from our point of view, but from a patient point of view, to keep it simple. So we're moving on to the area of the learning in terms of available technology. And I must say the technology is rapidly changing. Within a year, there'll be many more devices out there with various unique selling points. That's because they're all competing in terms of how accurate their devices are. So that's the MARC score. So from my personal experience at the moment, I think the best sensor out there that has a very good MARC score is Dexcom G6 and the Eversensor implantable CGM. Medtronic is definitely good as well, but it's catching up. So there are some unique differences. And don't forget, when we talk about CGM, you've got the real time where the information is being relayed in real time to a receiver, be it a phone or a reader, but also there's alerts coming through if it's appropriately set. And then the other form of so-called CGM is your flash glucose monitoring, which is your Freestyle Libre, which we are very, very familiar with. And there are some unique selling points. So for example, Dexcom doesn't need calibration. So, you take it at face value, and Dexcom has a license for it to be used for carb counting. You don't need to check your capillary glucose. Medtronic, on the other hand, would need 2 calibration, a minimum of 2 calibration per day, and the usage is up to 7 days only. Freestyle, no calibration, but you can use it up to 2 weeks, but obviously it doesn't alert you, unlike from what I've been told, Libre 2, when it comes to the UK, have some form of alert system. I think it's already available in Germany. And then we also have the Eversense implantable CGM. We have about 8 patients in our trusts, but unfortunately, Sensonics have withdrawn from the UK market because of poor uptake. So it will be available in Europe, but it's been phased out of the UK. So I've got a few patients I need to take them off once the sensor duration has expired, and the sensor can last up to 90 days. And there's more to come. So in summary, I think we need to get very comfortable with AGP reports. It is incumbent upon us as a specialist in this area to understand what it is. How do we explain it to our patient in a non-jargon way, but more importantly, show leadership for diabetes specialist nurses so that when they see the patient, because they spend more time with the patient than we do, that they know what they're doing. Always set individualized goals, and that's your time in range based on the consensus guidance. Always recognize what's the median, that's your dark line, what's the degree of variability, look at the time in range. And I always would keep it simple, focus on the part of the day that gives you the biggest return, and then come back, and see whether you need to change more. But never forget to look at the individual days, because sometimes you can get certain clues. So those are the granular data that it would be worthwhile going in, have a quick glance at it, because it might influence or inform you what needs to be done, and timely review. So really take full advantage of virtual clinics. There's no point seeing a patient and then 6 months down the line, they get seen again, you've missed the opportunity. So, we try our level best to get our diabetes nurse to see them within 2 to 4 weeks and upload the data and see how things are. And that's me. Any questions?
Absolutely brilliant talk as usual, Shafie. I think everyone can unmute your microphones and ask questions now.
Thank you very much, Dr. Kamaruddin. Can I ask a question?
Yes,
do you have any patients who are keen exercisers or runners or with sport? And what's the effects of the exercise on their variability of the insulin? Because this is usually a challenge for us as a registrar. I have a lot of people who are really keen runners, and we tried many times to try to adjust the insulin timing depending on their exercise that they are doing, because sometimes they are not straightforward doing just aerobic exercise. They go to the gym to do some aerobic exercise, then high strength exercise as well. And that will, because of the change of the physiology, will affect the curve of the insulin in a different way. How do you deal with this challenge in your clinic, in your experience?
Firstly, I'm going to say that I'm not an expert in exercise and diabetes, but I do have few patients, and I attended the second XTOD program. So you've heard of XTOD, Alistair Plum, I think.
Yeah.
It's a really, really good program. I would encourage people to go to it. And if you go to the DTN ABCD website, there's a section, a webcast for patients really in terms of exercise. But you're right, it is a huge challenge, and I would always go back to there are general principles, general rules, as you alluded to. So if you've got aerobic exercise, you're more likely to go down in terms of glucose change. If you've got anaerobic exercise, because the sympathetic drive, it goes up. And the majority of exercise, it's a mixture of both. If one predominates, then you see what happens then. But I think in one of Alistair's graphs in the webcast was quite nice to see that your starting point, your end point might be the same, but how you start your exercise is important. So for example, if you got a CGM and let's say your glucose, let's say is 8, but you've got an arrow pointing downwards, then your choice of exercise to begin with might be different. So you might start with some anaerobic exercise first, to minimize the risk of it going down, albeit you might also need to supplement with small amount of carbs to keep you, to sail safely. And then you monitor it throughout the exercise. Now, if your starting point is that sugar is high, and then you might want to do some aerobic exercise first, and then bring it down, and then monitor it, 60, 90 minutes into it, and then take the appropriate maneuver to address that. Because it's your starting point that's important, and how you monitor it 30 minutes, 60, 90 minutes, but the end point should be the same. You see? That's how I approach it. I keep it very simple. That's my rule of thumb, but I recognize that every patient is different. You have this general set of principles, then you really need to sit with the patient and go through the data, really break it into pieces. But the key thing is when they're using a CGM, they need to be able to key in data, what they're doing, what action they've taken, so that you can go through with them whether those actions are appropriate, and then tailor it. I'm sorry, I don't really have a clear answer to it, but my view is very simple.
No, that's very helpful.
And you should end about the same where you started off, but it's your arrow that's going to help you. And what's your sensor glucose at the time? So if let's say it's below 7 and the arrow is pointing downwards, you most definitely have to have some carb, And if you look at Alistair's website, he does, there's some general recommendation in terms of the amount of carb you need to take. But again, it also comes down to the type of exercise as well, So if you're a footballer, it's very different if you're a swimmer or marathon runner. So those are the key things you need to bear in mind. I must admit, I struggle with it, but I think it's taking a bit of time going through with it, and probably keeping. So I keep in touch with my patient through email. So they email me and I ask them to upload, and I sit down at night, go through it, because sometimes it's very hard to make those decisions in the clinic. I'm being very open and honest, because not easy. It's not easy. You see? That's my take.
Yeah. Thank you very much.
Welcome.
Any other questions, guys?
Can I speak?
Of course.
Okay, great. Thanks, Dr. Shafie. It's very impressive talk. Which cohort of patients do you think 670G would work? I came across patients, they say, we don't want the auto mode to take over my life. I would like to stay in control. So I'm just thinking, which patient you would like recommend 670G, on what basis you select them?
So when 670G came out in the beginning, I was very excited, and I must say, I thought, why are we bothering putting a pump on its own, or why don't we just patient straight away on 670G, for example? And I realized very quickly that not everyone needs to be on 670G. Actually, there's very good trials out there. So I'm sure you've heard of Diamond trial, for example, where they use Dexcom and compare CGM with MDI, CGM with pump, and they do as good. But it's case select about patient selection. So in answer to your question, for those patients who I would put on 670Gs once I've exhausted all those variables that's within my gift that I'm confident they've done properly. For example, I've really maxed out or fine-tuned their insulin to carb ratio. I'm confident their ISF is right. I'm confident their behavioral side, for example, they are bolusing before a meal. They're doing their level best to do, to rectify, and that immediately there's so many variables not within my gift, and the variability is still very, very high. The AGP changes is very broad. Then I would put them on 670G. And I must say, for those patients that I've been very careful with, they do extremely well. But I've had 2 or 3 patients lately that I made a very quick decision, say, let's just go with 670G. And what's interesting is, even before they go to auto mode, just in the manual mode for the first week, actually that's all they needed. They don't even need auto mode, you see. So they've got the insulin suspend feature, the 640G in the manual mode with the sensor in place. So they don't really need 670G. So I think it's the patients who tried the level best and despite that, has significant variability where they need real-time alteration in the basal insulin to benefit from 670G. But there's a caveat to it. And the caveat to it is you need to explain to patients who goes on to 670G is hard work. It's hard work in the sense that I always tell them there's 4 C's they need to follow. They have to bolus their carb 15-20 minutes before. They need to be damn good with their carb calculation, their carb ratios. They need to do corrections beyond hours, particularly if the sugars are high. If not, because once you hit 13 millimoles on 670G and it stays above 13 for 2 hours, it will come out from auto mode to manual mode. It'll cause a lot of patient distress. So they need to be proactively correcting if the sensor glucose stays above, stays high beyond 2 hours. And that's a lot of effort. And then the final bit is they need to download on CareLink on a regular basis to understand what's going on. That's less important. It's probably more for healthcare professionals like us to look at the data. So I would say it's hard work. And I've learned one thing. Again, it's about patient selection. It's about sitting down with them, explaining and managing the expectation. Because if you hear about 670G, the sensation is that, gosh, it's a what do you call a bionic pancreas, so we are halfway there. But the patient still needs to do a lot of work. So it's not really an automated system. That will come eventually, but at the moment, so it'll be interesting to see when 780G comes out. So I think as of last week, FDA gave the approval for 780G. So that might come up within the next 12 months in the UK. And that one, even the bolus is automated. So I don't know what the setup is. It'll be interesting to see. But I suspect they'll still have to do a lot of work. The reason being is it comes down to the sensor accuracy and the technology and the algorithm built into the system. So they have to create a lot of safety net, and the safety net relies upon the patient to do calibration, go off. Unlike Dexcom, they don't do any calibration, and Dexcom has got close collaboration with what was the other pump that Tandem. I don't have anyone on Tandem, so they've got this thing called Basal IQ and Basal IQ bolus, I think, coming up, IQ control coming up, and I have no experience in that, but it'll be interesting. So that's slightly different technology, so hopefully we'll explore that. But you're right, it's about patient selection, but those with big variability, but you need to manage the expectation.
Right. Thank you very much. Very informative. Thank you.
I think CGM in the form of flash or continuous real time with alert system in place. I must say nowadays I have very low threshold to offer CGM. Why? Because it makes a huge difference to the patient. So I'm quite philosophical in this, because I always tell my patients that I think I know a bit about diabetes, but there's one thing I don't know is what is it like to live with diabetes. I cannot imagine, doing blood sugar testing so many times a day. So I have a very low threshold to offer CGM. And why? Because for the first time, they will also subconsciously learn about the diabetes, and hopefully will be able to take evasive maneuver when they are at risk of hypo, provided they understand what they're looking at. So particularly in those kind of patients, I would definitely have a very low threshold to offer CGM. But again, if despite offering them CGM, they're still running into problems and pump is an issue and they've got lots of complications, I've had few patients I've referred to Prof. Shaw to think about, whether it's islet or pancreas transplant, because ultimately, particularly if they've got significant complications, and they're not getting away with technology, that's the way forward.
Excellent. Any more questions, guys? Because we have passed the hour mark.
Right. Can I ask another question?
Yeah.
What's your experience with the use of fias in the insulin pump? Is it really make any difference compared to the Novel Rapid? Because the reps telling us that it's acting more quicker, it's better for the people who are having a lot of hypos around the meals. So from your experience, do you think it make any difference compared to the people who are taking Novel Rapid?
So a lot of my patients who are on fias is mainly on pumps. I have very little experience of patients on fias on MDI, and I must say it does make a difference. And the reason being is it's about, that insulin kicking in early. So if you go back to my presentation earlier, it's about the timing of how quick the insulin kicks in, isn't it? Bolus burning before, then you are hit as the glucose is coming in. So that's the simplistic explanation to that. But even with fias, I think you want to bolus it a bit early as well, because you are really going to flatten that curve. There's one diagram I showed you where, how you can flatten the curve. So I quite like fias in pump. I have very little experience in MDI. But again, it comes down to the patient, because you can give them the best technology, you can give them best insulin, but if they're not doing the right thing and you've not established the rapport with them and they're on CGM and they don't know what they're doing with the CGM, it's very hard to get things right. So yes, fias is very helpful, I think, but it's in the setting of the right patient and the right circumstances.
Taking on the issue of fias, do you have any local data or experience to support its added benefit to novorapid in patients other than those who are on pump or pregnancy?
So again, of course, I don't do pregnancy as me, so I've been a while since I pregnant, so I have no experience in that, and I don't really use it in MDI for various reasons, because I feel that it's the right insulin for a pump, because you've got a utility within the pump to really influence how you deliver the bolus.
Yeah.
In MDI, I think in my humble opinion, I know the evidence is out there, you've seen the trials and so on, but I always take it with a pinch of salt. The downside is because you're bolusing, and the bolus. So if you think about the bolus volume that we give for a pump compared to MDI is much bigger dose compared to pump, largely because how you manipulate, how you bolus. So I think in my personal experience, although I can't say much in MDI, I think it's more suited for pump. But I don't have evidence to back that up because I've not done any audits for my caseload. Unless one of you guys want to do it for me, that'll be great.
Sure. Any other questions for Shafie, guys? Right. So if there are no questions, Shafie is happy to share the slides, so I will circulate them around. So I'm going to have to edit few bits and pieces of the cases out, and I will upload it maybe in a week or two to our website. Thanks, Shafie. Thank you very much.
Thanks for the opportunity, guys. Good luck, guys. Stay safe.
Thank you very much.
Wash your hands.
Bye-bye.
You guys take care. Bye.